assignment 4, difficult airway assignment. So I'm going to be talking about a case I had a few weeks ago. This was a 35-year-old woman. I did her pre-op assessment, and she was scheduled for a hysteroscopy. And she had a BMI of over 40, so that puts her in the morbidly obese category. Had a large neck as well as a Mallampati of 3. So she was an expected difficult intubation, and the plan for her was a conscious sedate. So preparatory actions for her, we had intubation medication drawn up. So we had succinylcholine, rocuronium as well, propofol and fentanyl. And we had the video laryngoscope outside the room. And so for the conscious sedate, she was just going to be wearing the non-rebreather, and we had her on a propofol infusion of 80 micrograms per kilo per minute. So it was going well at the start. She did require quite a bit of jaw thrust, but otherwise was tolerating the start of the surgery well. But once she was put back into Trendelenburg as the scope progressed, she went into what we believe was laryngospasm. She started desatting quickly and needed to be intubated urgently. So we pulled that video scope into the room, and at this point she was very stiff. We weren't able to bag. We gave the succinylcholine. She was still on that propofol infusion. And the first look with the video scope, she had tons and tons of secretion. So we thought she had like a negative pressure pulmonary edema from the laryngospasm. So afterwards so that first look unsuccessful, tried to come out and bag. She continued to desat. The lowest was down into the 70s, but we had a bougie available as well. So went in again with suction and the video laryngoscope and used the bougie to intubate. After that, she did take a while to come back up. We gave some Ventolin and needed quite high pressures and had a lot of secretions. We had to suction her out. But afterwards, so she stayed intubated for the remainder of the surgery, made sure she was fully awake, and had all our re-intubation supplies ready for when we extubated. But once we extubated, she did fine. And then later in recovery, she was completely appropriate and didn't recall anything. So that was good that there was no recall as well. So looking back on it, she did have the predictors for a difficult intubation. Maybe it would have been better to have a planned intubation at the start, but we were trying to avoid intubation altogether because of these difficult predictors. So maybe in another case like that, it might be better to do a lighter sedation, as the hysteroscopy wasn't expected to be very painful. It might have been nice to use like some midazolam instead, or a little bit of remifentanil to keep her asleep. And otherwise, I think the preparation we had for this woman helped a lot, because we had the drugs drawn up in advance. We had the video laryngoscope outside the room, which we immediately brought in. So that was our first attempt. And the bougie was ready as well, as it always is, off to the side, and suction is always ready and checked. So I think just having that preparation made a big difference in how quickly we could get that tube in, because we weren't successful in bagging at that time. So it could have been a lot worse situation if we didn't have all the available best equipment at that time. But otherwise, I think we had a good outcome because of the preparatory actions that we had taken. And then in hindsight, like I said, it might be better to use either plan to intubate right from the start when you have patients that might be a very difficult intubation, or use different lighter medications.